Grand rounds will begin at 11 a.m. in the Hillman Auditorium on the first floor of the Paredes building. Today's Grand Round speaker is Dr. Frances R. Levin, Kennedy-Leavy Professor of Psychiatry and Substance Use Disorders here at Columbia University. Her topic will be cocaine use disorder, a persistent problem in need of new therapeutic options. All are welcome.
Nice to meet you. Pleasure to meet you.
I brought you a bottle of water.
Oh, thank you.
Okay.
Thank you.
Do you need anything else?
No, I think I'm fine. We can just keep from it. Yes. That's it.
So,
Small group today.
no, I think a lot of people will end up showing up.
Okay.
And then at 12:30, I'll take you upstairs
Okay.
for lunch with us.
Great, great, great. Thank you. Congratulations on.
Oh,
What are you interested in doing? Pneumonia, do you know?
it's a big question of the year,
Yeah,
right? I've been telling
yeah.
everyone that I feel like a sophomore, just not decided.
Uh-huh.
But I think about doing a public psych fellowship
Oh,
here.
good, good. apologizing that they can't come today. They go, that's fine.
I'll represent.
They'll represent the division. Yeah, no,
Can I tell you a funny story?
yes, yes.
There's a movie.
Really?
Well, it's kind of
Once you eat that, you don't eat any other food.
no. It's a blanket medicinal.
Oh, medicinal purposes, okay.
It's
Right, it's so expensive.
so expensive. It's a good movie.
I'll have to see what it's called. What is it called? Shadow.
Sea of Shadows.
Sea of Shadows, yeah, okay.
What about that one? Okay.
Funny, okay, good.
Criminals.
Right, right.
Yeah, the thing is,
You thought of it today. Okay, yeah.
Yeah, of course. This is weird.
I'm sure they will.
It's crazy how like it's like I got my wedding back. It was literally I mean I got coming yesterday. They left anything. That's the thing, it's like after this. No, I yesterday came out. But it's interesting because like, I mean, I do. I sent the pic.
Good morning. I'm Dr. Melissa Arbuckle, the Vice Chair for Education, and it's really my pleasure to introduce today's speaker. I just had one announcement, and that is that our Grand Round series will recess for August, and we'll restart on September 11th. So today, I'm particularly excited to introduce Dr. Frances Levin. It's always a treat to have one of our own faculty members present and to hear about their work, and also to learn a little bit more about them. So Dr. Frances Levin is the Kennedy-Leavy Professor of Clinical Psychiatry at Columbia University and Chief of the Division of Substance Use and Director of the Addiction Psychiatry Fellowship Program here. She graduated from Cornell University Medical College and completed her psychiatric residency at the New York Hospital Payne Whitney Clinic. She is principal investigator on several federally funded grants, including a Medication Development Center, a T32 NIDA-funded Substance Use Research Fellowship, and a K24 Mid-Career Investigator Award, and she's a collaborator on several other grants. Her research interests include pharmacologic and pharmacotherapeutic treatment interventions for cocaine and marijuana abuse, and treatment approaches for comorbid substance use disorder with attention deficit hyperactivity disorder and other psychiatric illnesses. Dr. Levin has published over 200 articles and book chapters and serves on several advisory panels. She's an editorial board member of 3 journals and past president of the American Academy of Addiction Psychiatry. So please join me in welcoming Dr. Frances Levin.
Well, I am really delighted to be here. You know, it's funny, in preparing this talk, when I talk in other places, I'm always very comfortable and calm, and then when I came to my home base, it's like, oh my God, I'm in front of all of my friends and others, and so I may be a little nervous than I normally am, but I think I'll get through it just fine. So I'm delighted to be here today, and I'm going to be talking about cocaine use disorder, a persistent problem in need of new therapeutic options. And what I hope to actually convince you is there are therapeutic options that are actually out there, and there's a lot of therapeutic nihilism about treating cocaine use disorder. And sort of being an eternal optimist, I'm going to try to convince the rest of you that it's not as negative as it might seem on the surface. So this is just my salary support, New York State, federal, and also I consult with Major and Minor League Baseball. And in the last few months, I've been putting this slide up just to remind me of how important Herb Kleber was to my career, but also to many of the faculty members that you see here. This actually, it's herding cats, actually, to get all the faculty together in one picture. So we've got about 10 faculty members missing, but the original core, which is right in front here, really all of them, Suzette, Richard, and Ned in particular, and of course Herb, were all instrumental in my career, and I think without mentors, you really can't get there in academics. So I'm very appreciative, and we all still miss Herb a lot. He was really instrumental in all of our career. So how did I get interested in pharmacologic treatments for cocaine? I'm going to, I figured that I'm with family right now, sort of, so I can be a little bit more casual in my talk today. So I'm going to talk a little bit about how I got to where I am and also why I got interested in cocaine. Well, as Melissa said, I was a resident at Cornell. It wasn't Weill back then, it was just Cornell Medical Center. It became Weill. And during the time I was there in the mid-'80s to late '80s, there was this rapid rise in crack cocaine use. And here I was in a psychoanalytic program, it was primarily psychoanalytic when I was going through, and I was interested in addiction, particularly when all this problems with cocaine were going on in New York as well as the rest of the country. And there was one faculty member, Richard Francis, up at Cornell Westchester, who was on an alcohol unit. It wasn't even an addiction unit, it was an alcohol unit. And from that experience, you could actually talk to patients and you could intervene and you could do cognitive behavioral therapy rather than just sit there and be quiet, is how I perceived psychoanalytic training. I was a fish out of water at Payne Whitney, but I found my niche and got interested in addiction. And then, as hopefully some of the residents get a chance to do, I went to an APA meeting, and there was Herb Kleber, who I didn't know at the time. He was sort of an iconic sort of star in addiction at the time, with Frank Gavin, who had a lot of charisma and personality, and they talked about dizipramine as a treatment for cocaine use disorder. And the reason that was really interesting to me was that back then, then, I mean, we're talking mid-'80s, late '80s, there really wasn't much treatments for substance use disorders that involve medication. If you think about treatments for opiate use disorder, the only treatment out there was really methadone, and you had to be in a methadone program. There wasn't buprenorphine, there wasn't extended-release Vivitrol, there wasn't really many alcohol treatments except disulfiram. So it's still a novel idea to think about treating a substance use disorder with a medical therapy, with medication. To me, it made a lot of sense because I was being trained as a physician, and why aren't we thinking of it as a medical disease that you could have medical interventions along with psychotherapeutic interventions? So this seemed very exciting to me, and I started a study looking at bromocriptine. What I will tell you was a miserable failure. I didn't know what I was doing. I didn't have the right support. I was trying to do it as a resident. It was a miserable failure, but that was okay because you learn from your failures. And I went to NIDA after that. I was at the Addiction Institute at NIDA, the intramural branch, and I was a fellow, the first fellow at the University of Maryland. And I then embarked on a trial looking at carbamazepine. Well, you'd say, why carbamazepine? Well, the reason carbamazepine was of interest in the early 90s was there was a person by the name of Jim Halakis, who had done open trials and found that it was very effective, he thought, for cocaine dependence, was this theme that cocaine kindles the brain and it causes increase in craving because of that, and that if you treated a person who had a cocaine dependence with medication that would help with stabilization of, an anti-seizure medication, anticonvulsant, it might be useful. And in fact, we all, three different groups branched out and did a trial on carbamazepine. I initiated the trial at NIDA, and there were two other groups. And then a few years later, Drug and Alcohol Dependence published the 3 trials. They all were negative, and to the credit of Drug and Alcohol Dependence, they said we have to be publishing negative trials, and therefore we're publishing all 3 of them. And to me, this was great, because then it launched a career of negative trials. So I became the queen of negative trials. You can't get your articles into American Journal of Psychiatry often with a negative trial, but you can in the drug treatment journals. So that's what I started to do. So in the 30 years after my residency, I realized when I went to the residency dinner that at that dinner it had been 30 years since my residency, which I couldn't believe. And preparing this talk, I said, well, I've done research in a lot of other areas, but what about the area of cocaine use disorder? And there's been many drugs and vaccines that I've studied for cocaine use disorder. And I've also studied drugs with cocaine use disorder and comorbidity, which frankly probably is near and dear to my heart as a psychiatrist, is trying to find interventions because so many patients with cocaine use disorder also have psychiatric comorbidity. So what's the punchline? I'm going to be spending the next 45 minutes talking to you, but what's the punchline before I get started? After I say this, you can go to sleep now. But what's the punchline? First is that there's really no need for therapeutic nihilism, and I hope I can convince you of that. I still think there are several avenues to pursue, and there needs to be, what you really need to do this research, or any research for that matter, is persistence and hopefully some financial support to pursue what you're interested in. And what I will say is where NIDA is focused right now is the emphasis on finding new medications and new mechanisms. And I think that is great, and that's what NIDA is doing at the moment. But I would argue that there are also available medications that have been studied a lot, and I think sort of dismissed too early. And I'm going to show you the data to support that, and I think they still deserve investigation. Because a lot of what we do in psychiatry is taking medications off the shelf and using them for other purposes, and we do a lot of medication treatment off-label. We tell patients that. And the fact that these medications exist and have long safety and long track records suggests that we maybe are throwing them out prematurely. So that's really what I'm going to be talking about. So for just a minute, what is cocaine? Cocaine's a powerfully addictive stimulant drug. For thousands of years, people in South America have chewed and ingested the coca leaves, which is the source of cocaine, for basically the stimulant effects. It's very hard, arduous work that people might be doing in the Andes or other parts of South America, and it keeps that energy up, and it's used in that way. The problem is when you change the route of administration, when you go from chewing it and it's a slow absorption, slow uptake in the brain, it's very different than when you start changing the route of administration to either snorted or smoked or injected. The purified chemical is called cocaine hydrochloride. It's isolated from the plant more than 100 years ago. And before the development of synthetic local anesthetics, surgeons often used it to block pain. So therefore, cocaine is a Schedule II drug, actually. It's not Schedule I. I mean, it's ironic that, let's say, cannabidiol, which has no real abuse potential, we don't think, is Schedule I, but cocaine is Schedule II because it has some medicinal purposes, so that's why it falls into that scheduling. Here's just examples of how cocaine was marketed in the late 1800s. It's ironic, right? Because we think about opiates, and the same thing happened with opiates in the 1990s, in which we thought that for the vast majority of people, opiates were safe, and the reality is we found differently. Well, back in the 1800s, late 1800s, cocaine was given and really targeted to mothers to give to their children for toothache, to make them healthy and strong. And iron bitters, for example, was an elixir that was laced with cocaine. So this was quite common. And they're beautiful, sort of beatific kind of pictures, right? And it was also targeted towards adults. I mean, probably most of you know that Coca-Cola originally did have some minor amounts, minimal amounts of cocaine in it. And the thought is that it was a temperance drink. You know, at the turn of the century, alcohol was all bad, and that you take Coca-Cola or you take products or elixirs that have cocaine, that gives you energy, and that's a positive thing. There was tablets that were produced by Burroughs Wellcome called Forced March. And Ernest Shackleton actually was an explorer, some of you know, in the Antarctica, and he sort of touted this as a way to give him energy and keep him going. Well, the reality was that these products flew off the market, flew in the market, sort of the way opiates did, and the federal government got increasingly concerned about the excessive demand of these drugs. And this was when, by the way, Freud wrote his treatise on uber cocaine and was still touting it. For those of you who don't know, Freud had a cocaine dependence and actually injected cocaine, and it, on his own somehow managed to stop. But he was somebody who was touting it at the same time the federal government was getting more and more concerned, such that it started to phase it out through both the Pure Food and Drug Act in 1906 and then the Harrison Act in 1914. And so eventually cocaine went underground. And so today, or what I will say, is that cocaine never really went away. Cocaine remained popular in the 20s and 30s. I don't know if some of you are old enough or know about Cole Porter, but Cole Porter wrote, "I Get a Kick Out of You." And in the lyrics of that, he wrote, "Some get a kick from cocaine. I'm not sure that if I took even one sniff, it would bore me terrifically too. I get a kick out of you." That was some of the lyrics. They actually took out those lyrics and whitewashed the lyrics because later on, when Anything Goes, or one of the plays came out in which it was in, because they didn't like the fact that cocaine was referred to in a positive way. But anyways, people didn't think it was much of a problem. People forget, the same as we do with opiates. And then the 80s hit. And what happened was they learned how to change the formulation, so no longer was it just the powdered, but then you could take cocaine in the form of crack cocaine by mixing cocaine hydrochloride with either ammonia or with bicarbonate and heat it up, and you could wind up with crack cocaine, which provided a very powerful immediate hit and, of course, had the potential to cause higher rates of addiction. It's called crack cocaine because when it would burn, it would make sort of a cracking sound, and that's where it came from. In any case, a lot of it went underground, and that's sort of what persisted. And then when people, of course, realized that there were problems with cocaine, like we now do with opiates, then use over time began to fall. So, given all of that, why am I up here talking about cocaine when we're in the midst of an opiate epidemic? I was thinking about what to talk about today, and I was really I was toggling between opiate dependence or marijuana dependence or cocaine. And I decided to talk about cocaine because that's where I started, and that was the initial research that I had done. And it remains a persistence problem, which I think we're all forgetting about, as we are not thinking about alcohol dependence, which is still the major problem in the United States. Everybody's right now focused on opiates, with good reason, because the high rates of overdose, but it doesn't mean that these other issues aren't also important. So right now, stable use in the United States is about 2.2 million. That's down from close to 6 million in 1985 when I got interested in studying cocaine. Approximately a little less than 1 million people, Americans, had a cocaine use disorder in 2017. And the use is not just the United States, but also in Europe, and there's been substantial increases in Australia and also in South America. And while we generally don't think of cocaine resulting in overdoses, this is unfortunately changing. If any of you trained in the 80s or old enough to remember, there was a very famous case with Len Bias, who was this all-American recruit with the University of Maryland, and he was being recruited for the NBA. The Celtics were picking him up, and he died of a cocaine overdose and arrhythmia, and it was a traumatic thing for the country. I mean, everybody was very upset about that, and that was in the midst of the epidemic. So people from that time period, we remember, not that everybody, of course, I don't want to be alarmist, but there was risks associated with using cocaine, and we had sort of forgotten that. What we do know is the opiate epidemic. So I'm putting this slide up just to show you what's been going on with the opiate epidemic. And as you can see, actually, you can't see it too clearly, but there's been 3 waves of the opiate overdose epidemics, with 3 phases. The first phase was overdoses due to prescription pills. Then it became heroin. And now, right now, what you see is that sharp rise up in the blue line right here is due to synthetic opiates other than methadone. That's generally fentanyl or fentanyl analogs. And this is really what's driving the overdose rates now, because a lot of heroin and other drugs are being cut with it. But what also is interesting is what's going on with cocaine. As you see that cocaine is going up, and this has alarmed Nora Volkov. She's talked about it in several meetings. And so we're sort of losing what's going on with cocaine because we're all focused on the opiates. So what about what's going on? So here is overdoses involving cocaine, and as you can see, that also is going up. Now, most of it is due to mixing with synthetic opioids, that's also been what's pushing up the the overdose. But there are people with cocaine who are overdosed without opiates being implicated. Now, you may ask, like I did, and I had to go to the internet to figure this out, why are we seeing opiates with the cocaine? And, a small percentage might be people who are speedballing, who are intentionally choosing to take opiates with cocaine. But the other piece of this is either malevolent, which is that dealers, if they mix the fentanyl, which is so much cheaper than either cocaine or heroin, they can sell it, and they're selling it by grams or whatever, and so therefore they can charge a lot for something that's cheaper for them. And the other part is inadvertent. The other thing that Keith Humphreys talks about is that they're using the same pieces, the same equipment when they're making heroin versus when they're making cocaine, and that, even if you have just a tiny bit of fentanyl left over, it will get into the cocaine. So they believe that some of this could be inadvertent. So when a patient comes and says they have a problem with cocaine, you really have to worry that they may get some fentanyl and they could overdose from that, and I think that it's not safe for that reason as well. So what are the negative consequences of cocaine? I've talked mostly about the overdose risk with inadvertent opiates, but also, as we know, is that it causes a lot of vascular changes and risk of cardiovascular risks such as myocardial infarction, hypertension, stroke, seizures, and there's other health risks like patients who smoke or use cocaine are also cigarette smoking. There's often psychiatric comorbidities. The big thing that I think is not being emphasized in either the opiate epidemic or any drug abuse discussion is the mental health and the psychiatric comorbidity. And I think we are definitely situated as psychiatrists to deal with that. And I can tell you in most treatment programs, unless you have severe psychosis or bipolar illness that's obvious, often psychiatric illnesses go untreated, and if you don't treat the psychiatric illness, you're at higher likelihood to not have success in terms of the substance use treatment. And also HIV risk is much higher among individuals who use cocaine. There's thought to be immunologic reasons as well as higher risk sexual encounters as well as injection as reasons of why there are higher rates of HIV. So what about treatment? That's really why I'm here today. And that is that right now there's about 500,000 Americans in the U.S., 500,000 Americans who go for treatment every year for cocaine, and almost all are treated with a psychosocial intervention. And, that makes sense, right? Because there's no FDA-approved treatments. What I will tell you is even for all the other substances in which there are FDA treatments, it's woefully undertreated. And if the one thing I can say to the residents is push your supervisors or whoever else to get experience in treating tobacco or alcohol or opiates with a medication-assisted treatment, because if you don't do it now, it's very hard to get people to do it later on after their residencies. The treatment that's probably been shown the most effective is contingency management, and that is where you basically give vouchers and increasing ratios of payment or cash to basically produce negative urines. And it's not widely used, even though it has the greatest empirical support for it. And there are lots of reasons why. It's hard to think about how to get it covered by insurance or how to do it. But some states are actually coming up with innovative ways to include that as part of the treatment. There are certainly other approaches like cognitive behavioral therapy, mindfulness treatment. All of these approaches have some benefit, but they're modest in effect. They reduce drug use, which is good, most of them, or all of them. But abstinence is a high bar for a lot of these treatments. And the thought is that maybe combining a psychotherapy with a pharmacotherapy that might help either increase motivation or increase the craving, increase the withdrawal symptoms, what you're targeting, that then maybe you'd have a decreased likelihood of using. So that's been the thought for the last 30 years. Like I said, there's no FDA-approved treatments. But still, despite that, there's still substantial research going on, and research is being funded to study cocaine, although at the moment it's being dwarfed, not surprisingly, by the opiate epidemic. So what are the models of pharmacotherapy? Before I talk about cocaine specifically, we need to think about what are people targeting. And what I will say is that the treatment literature after 30 years is somewhat of a mess. And the reason is that there's no clear treatment outcome measure. Alcohol and tobacco is probably the closest, in which in alcohol, basically it's no or very few heavy drinking episodes, and they define what a heavy drinking episode. Tobacco, it's abstinence. But with marijuana and cocaine, in which there's no FDA-approved treatment, and there's often quite a variety of ways in which people assess outcome, and it's not really clear what the outcome should be. The easiest one is, of course, abstinence, because we can sort of all believe, okay, if somebody is abstinent, they're probably going to be doing better. It's more confusing when you think about, well, is reduction in use a reasonable goal? So in terms of pharmacotherapy, the treatments that get developed are either, let's promote abstinence. Let's say take someone who's an active user and see if we can have them become abstinent, so you're facilitating abstinence, and there are drugs that might target that. Or let's look at people who already have become abstinent. Either you've done contingency management and gotten them abstinent, or you've hospitalized a patient and brought them into an inpatient unit, and then does the medication help sustaining abstinence? And there are some medications that are thought maybe to work better for that reason because of animal work with cue-induced reinstatement and drug-induced reinstatement, which is the thought is that certain drugs, such as maybe topiramate or other NMDA antagonists, might do better as a relapse prevention agent rather than facilitating abstinence. The other approach is just treat the neuropsychiatric sequelae, so treat the withdrawal symptoms with medications, sort of symptomatic relief, or treat the mood disorder, even if it's substance-induced or not, and also treating cognitive deficits. That's a new area that people are very interested in because this idea that, cocaine over time does cause problems with cognition, and that if you can help people think more clearly, have greater attention, maybe make less impulsive choices and think things through as they would do with cognitive behavioral therapy, that it would enhance the psychotherapy if you could remove some of the cognitive deficits associated with cocaine. What is true is most treatments that are developed for cocaine or any drug of abuse, the thought is sort of management of a chronic disease. It's not thought that you can cure it. It's thought that you can treat it like you would hypertension or diabetes. Now, if you think about it, if somebody gets treated for hypertension, if they change their diet, if they lose weight, if they do all these things, over time you might not need to use the antihypertensive. That's sort of the thought about cocaine, and we have a lot of question in the field about how long do you leave someone on methadone. You would think after 40 years or 50 years of methadone, we know how long to keep people on it, and it's still an N of one at a time in making that decision. There's a lot of interest at NIDA right now to look at how long do people have to stay on buprenorphine. It's interesting because there's all this emphasis on how long does people have to stay on addiction medications. You don't hear this controversy about how long should somebody stay on a diabetic medication. It's like, for some reason, you want to get people off as quick as possible. But we still think of it as a chronic disease, and like I said, there's no definitive answer. Usually we go by psychosocial functioning and have a lot of areas of somebody's life changed, such are they ready to come off the medication. And I've had patients over the years who are dying to come off their medication, and then other patients who absolutely never take me off of this. This has kept me stable, and so you have sort of both extremes. So how does cocaine produce its effects? Well, let's talk a little bit, and most of you who, maybe some of you here aren't neuroscientists, this is very simplistic, but you have the brain's mesolimbic dopamine system, its reward pathway, and it's stimulating by all different types of reinforcing stimuli, such as food, sex, many drugs of abuse, including cocaine. And this pathway originates in a part of the midbrain called the ventral tegmental area and extends to the nucleus accumbens, one of the brain's key reward areas. But I think the important point I make is that besides reward, this circuit also regulates emotions and motivation. And one of the factors that is really key in changing people's view or perception or relationship with drugs, and particularly cocaine, is changing their motivation. And what can we do to do that? So now I'm going to just go through, when I was preparing this talk, I was thinking, how am I going to present? There were so many medications out there. So I'm making these sort of categories, and not everything fits nicely into these categories, but I'm a simple person, so I like having categories. So it's agonists, antagonists, novel mechanisms, which was sort of my basket category for a number of drugs, combined pharmacotherapies, which is an interesting area of development. It's really underdeveloped at this point. And then targeting psychiatric comorbidity with the thought that if you treat the psychiatric disorder, that may drive the improvement of the substance use disorder. Ed Kanzian has championed this idea as a self-medication hypothesis. People have poo-pooed it. I would say in clinical practice, I see this. It's like one of those things that you see, but it's hard to prove. And I think if the psychiatric disorder gets a lot better, then you're going to see an improvement in the substance use disorder. And often, like I said, that's hard to show. This is a cartoon showing the way cocaine works, at least in terms of dopamine. I know that it also works as a monoamine reuptake inhibitor, not just for dopamine, but also for serotonin and norepinephrine. But the focus of most of the research that's been done over the years is the focus is on dopamine. So as you may know, cocaine blocks the dopamine transporter such that you have an increased concentration in the synapse. Amphetamine formulations, particularly methamphetamine, you wind up with much more potent release or availability of dopamine in the synapse, because not only does it block the dopamine transporter, but it also blocks the vesicular monoamine transporter, which results in more dopamine in the cytosol, and also works on certain enzymes such as tyrosine hydroxylase. It enhances the activity of it such that you actually wind up with more dopamine and then dopamine. So methamphetamine is more potent in some ways than cocaine, and there's thought to have more derangements physiologically and at the brain level compared to cocaine. So now I'm going to talk about the treatments that have been done. And I put up this slide because, I've been trained very well by my colleagues who are human behavioral pharmacologists. I tended to do the latter part, or the right side of this, which is, okay, I'm a psychiatrist. Somebody's telling me they're not sleeping well. I'm going to give them something to sleep. And this is frequently what we all do. Okay, I'll try navazodone. And so a lot of the studies that have been done looking at cocaine have focused on this, which is they haven't done human behavioral laboratory studies. They haven't done animal studies with non-human primates. They've jumped right to the clinical trials. And usually clinical trials, unless they're an open trial and then they're not that meaningful in some ways, then you get a lot of these clinical trials that have been done. They're a lot more expensive, and frankly, most of them turn out to be negative. The slide says there's 64 drugs, and there's been over 100 trials. I think the number's probably up to 70 at this point. This study was done review was done in 2016. What I'll bring your attention to, let me go back, is how many drugs have been studied where they first do the non-human primate study, which means you expose a non-human primate, usually maybe a rhesus monkey or another non-human primate, in which you expose the animal to the drug, and then you maintain them on a medication, and they can choose between that and, let's say, a food pellet. And what they've done some work using that, but most of the work that's been done besides the treatment studies have been the non-human, well, I guess the non-human primate there's been more, but the human laboratory is what we do a lot here at Columbia. So Richard Fulton, Suzette Evans, Meg Haney, Sandy Comer, all do a lot of work in the human behavioral pharmacology laboratory, and that basically is a setting in which you can bring in, generally it's non-treatment seekers, and you expose them to the drug of choice, and you maintain them on a medication. And the idea is does the medication help with withdrawal? Does it reduce subjective effects? Does it reduce self-administration? And it's thought in a review that both Sandy did and another one that Meg Haney did, basically that it's a good marker for whether or not a medication might work in the human treatment setting. And so that would be ideal. So what's pushed forward is an idea by Zotti and William Stoops and Craig Rush were on this paper, was that ideally you'd like to do stuff in the human laboratory with the non-human primates and then move to the treatment. As you can see, only 10 drugs fit this criteria. What I will say is ketamine now does, so I'll talk about ketamine later, but basically these were the drugs that have been looked at. And of interest, based on this review that they did, I was not part of this review, but I agree with it, the only drug that's predominantly been shown to work both in the non-human primate paradigm, the human laboratory, and the clinical treatment is dextroamphetamine, which is obviously controversial. And that's been my research for the last 20 years, is doing controversial research. So that's been the thing that they say has shown the most promise across all three paradigms. So I'm going to be talking about agonists then, right? Because I just said that based on what I showed you. Agonists are being loosely defined, either monoamine enhancers, reuptake inhibitors, indirect agonists. I'm not going to have time to talk about every drug, so I'm going to just talk about what I think shows some promise. So agonist approach. The idea behind it is that, yes, initially you get more dopamine in the synapse by using cocaine, but then over time, with chronic abuse, you wind up with reduced monoamergic functioning, such that people have anhedonia, anergia, impaired concentration, increased impulsivity. These are all things that are seen more likely in heavy cocaine users than those without. And the thought is that providing an agonist may restore some of this monoamergic functioning and reverse the deficits associated with ongoing use, and may also help with craving. So that's sort of the rationale behind it. There are concerns about abuse and diversion, and one of the things I say is that if you're going to use a controlled substance, you have to use it very carefully. I don't write for a month's supply of stimulants in somebody who's recently in treatment. You have to use it very cautiously. You have to worry about cardiovascular effects. What I will say is people have looked at stimulants being prescribed in clinical trials, and interestingly, the loss of pills are the same in the placebo group as it is in the treatment arm. So that's a little reassuring. And I worked in methadone programs giving methylphenidate, and I think after 5 or 6 years, I would have heard from one of the counselors that there's a thought that the patients are misusing it or abusing it. They don't particularly like it. If they can get cocaine, they just use the cocaine. What we're giving them is so much weaker than what they could take otherwise. I mean, you certainly have to potentially worry about diversion, but the group I would say I worry about diversion the most is like a college student who is using or abusing drugs and has ADHD and isn't in treatment for their substance use disorder, and they're not safeguarding their meds. So I'm not sitting here lightly suggesting go ahead and open your prescription pad or go on the electronic prescribing and prescribe it, but you have to do it carefully and be aware that this risk exists. Certainly, these medications have good patient acceptance. They're familiar with the drug. They know what the subjective effects will feel like. The reality is many clinical trials for cocaine have failed because of poor adherence. And that was the big statement that Phil Skolnick used to say, the head of medications development, is that the trial failed the drug. And he used vigabatrin as an example of a study that was positive in Mexico, and then they spent millions of dollars studying in the United States, and they felt that adherence was one of the main reasons it didn't work. My experience with stimulant medications is patients actually don't mind taking them. Well, perhaps that's not surprising, but that's important if you're running a clinical trial, or you've got to come up with methods to ensure adherence. That's true of all clinical trials, but particularly when you're dealing with substance abuse populations. So this is certainly not my expertise, but I wanted to just put this out there. This was just published. I couldn't believe it. I was preparing for this grand rounds, and I saw this. It was just published a couple of months ago because I was going to put up a slide by Craig Rush and his group, and Joshua Lyle is part of Craig Rush's group. And the methodology wasn't as great, and this was much better, actually, both the study done with the non-human primate as well as the human studies. And basically what you see is when people are getting amphetamine as a treatment, or the monkeys are getting it infused in this case, that their choices of using cocaine versus a food pellet go down while they're actively on cocaine. That's the lower graph on the bottom, but it doesn't seem to affect food. So this is a promising thing, that they're able to infuse the amphetamine and actually isn't affecting their food intake, but it is reducing their cocaine self-administration. And then the same thing was found in humans. I went to Richard before I gave this talk because the earlier study by Craig Rush really didn't use high enough doses of cocaine. In this study, this was actually, they were given infusions of cocaine rather than intranasal, which was the older study. And in this study, again, what you see, if I can get the thing to work, it's not, there we go. What you can see is that the group that's on placebo compared to the amphetamine group are choosing cocaine at substantially higher rates, significantly so, even at the high dose of cocaine, although the difference doesn't look significant, it actually is. And I think if you find something in the lab that are non-treatment seekers choosing to use cocaine less, that is of interest, obviously, because it's a holy grail to get patients to make that decision not to use cocaine, particularly after they've received one dose of cocaine, not to go on and take another dose. So what does the clinical trials tell us? Well, the clinical trials mirror what I just presented in the non-human primate and in the human behavioral laboratory. This was a study done by John Grabowski. He was really out there many years before everybody else looking at amphetamine as a treatment for cocaine dependence. And what he found is that initially, when people were on either 15 or 30 milligrams, it didn't really do very much. But then when he jumped the dose, which is, I guess, the controversial part, is he went from 15 to 30 milligrams in one group and then 30 to 60 in the other group. Once he got to 60 milligrams, there really was a drop-off in proportion of positive urines. Now, I'm bringing this up because, again, should that have been the outcome, all you need is one negative urine one day because cocaine doesn't last in the system. Would it have been better if he looked at, continuous abstinence? But nonetheless, it does suggest less cocaine use. Whether that's clinically meaningful, we have to wonder about. But this is a high bar of getting cocaine users in a clinical trial to show a difference between an active arm and a placebo arm. The other study by Mark Mooney probably is even more controversial because they actually gave disoxazine, which is methamphetamine, oral methamphetamine, which isn't as available now for the treatment of ADHD, but it was at one point. And this makes another interesting point, is that he gave this to cocaine abusers, and either they got the immediate release, which they were taking 4 or 5 times a day, and frankly, most of the patients didn't want to take it that often. They take the morning dose and then not take anymore, or the group that got the sustained release. And as you see, among the group that got the sustained release, there was a real drop-off in positive urines. And this is remarkable. Now, of course, there was very high dropout, and there were lots of limitations with this study. It was a small study, but at least it's in the right direction. So to me, this was very important to demonstrate. And what it also demonstrates is that if we're better off giving patients, particularly substance abuse patients, drugs that they only have to take once a day. It sounds like a simple thing, but many studies were done with 3 times a day dosing, and you can forget that patients were, I can't remember to take doses 3 times a day. How can we expect our patients to do that? So, that was remarkable. And then this study just came out, and it also supports the same thing. This is a study in heroin-assisted treatment patients. In Amsterdam, unlike the United States, they can actually maintain people on heroin, and that's a whole other discussion about whether that's a good thing or not. But these are like recalcitrant, difficult to treat. They had failed treatment for targeting their cocaine dependence, and after the failure of the cocaine treatment, then they were given sustained-release dexamphetamine, again at high doses, the Grabowski dose, which was 60 milligrams. And regardless of the outcome they looked at, days of cocaine use in the trial, consecutive abstinence, absence at the end of the trial, which is a hard bar because what you have to have for end of the trial is they have to show up and be there, and often half the sample usually drops out. Not this sample because they were in opiate treatment, but generally people drop out, and so if you have to make that high bar at the end of being a treatment responder, you have to not be using at the end of the study, and you have to show up at the end of the study. So that's a pretty high bar, and every outcome they looked at was positive. So that's interesting. I, of course, unfortunately contributed to the negative literature regarding lisdexamphetamine, again, because that's what I do. So we did a study with Mooney, but there were problems with this study. This was a small trial. There were only 40 patients. Half the patients dropped out. And if you looked at an intent-to-treat analysis, whether you imputed cocaine-positive urines as negative or missing, positive or missing, there was no difference. However, if you look at this last graph, this represents the completer sample, people who entered the study and stayed to the end. Now, I know this is not ideal statistically, and that missing data is missing, which I think is reasonable because, if somebody doesn't show up for one visit in a 3 times a week study, if that's considered positive and the 2 urines around it are negative, it doesn't make sense that that's a positive. So I think missing data is not unreasonable, and this was significant. I think what it just tells me is, A, we needed a much larger sample, getting people to be compliant and staying in treatment would have been better, and also the dose should have been, I think, particularly higher, because 70 milligrams of lisdexamfetamine is about 30 milligrams of dextroamphetamine. So I think if the dose had been higher, we would have done better, and I wish we were funded to do that, but we haven't been to date. So what are we doing? Ken Carpenter, who is an amazing collaborator to work with, who would you give a dextroamphetamine to? Well, you wouldn't give it to somebody when they're first coming for treatment, probably. You'd want to have them try other treatments, and that really it would be held sort of like we think about TMS or ECT, that we're not going to jump into it right away. You're going to try other things first. So what Ken and I are doing is we're doing a study that involves a behavioral intervention first, using computerized assisted treatment. And then the thought is sort of based on the work of Diana Martinez. Diana Martinez has done a lot of work showing that there's a reduction in dopamine transmission among drug abusers, all different types of drug abusers, particularly cocaine abusers, using PET imaging and raclopride. So the idea is that in her study, she found that those who had decreased transmission as a group were less likely to respond to a behavioral intervention. So what we're doing is we're not doing the PET scan up front. Instead, we're doing the behavioral intervention. And then if people fail that behavioral intervention, then we're going to add on the pharmacotherapy. So that's what we're doing right now. We're comparing a behavioral treatment to behavioral treatment with mixed amphetamine salts, amphetamine, or Adderall XR. I'll say Adderall XR right now because it's shorter. Adderall XR, we're using relatively high doses. We're using 60 milligrams, comparing it to placebo, and then see, after a group who is not able to maintain abstinence, what happens when we randomize this. And this is probably, smart design, what would be more likely to happen in a clinical setting. So we're going to hopefully be done with this study in the next year or so. Well, what about other options? Another drug that got a lot of press for a while was disulfiram. And why would people think disulfiram might work? Some of you probably know that disulfiram is an aldehyde dehydrogenase inhibitor. It blocks aldehyde from being broken down, so you get this disulfiram reaction if you drink alcohol. But it also is a dopamine beta hydroxylase inhibitor. And the thought is that if you block the dopamine beta hydroxylase, you both increase dopamine and lower norepinephrine, and that maybe this indirect way of increasing dopamine would help with becoming abstinent or facilitate abstinence. So Kathleen Carroll did a study looking at disulfiram versus placebo. She looked at 2 different types of treatment, CBT versus interpersonal therapy. The therapies didn't matter. What mattered was whether or not they were on disulfiram. The disulfiram outperformed placebo. So that was exciting. And then Rich Schottenfeld did another study. Everything that was positive was done at Yale. Everything that was negative was done at UPenn. But the positive studies were all at Yale. And, they were off to the races. Disulfiram is going to be the cure. Of course, you got to make sure these patients aren't drinking or that they're willing to not drink. But maybe part of it is if they don't drink, that helps serve as lack of a cue to get them to start using cocaine. So whatever. And then Costin's results weren't as positive, although he was at Yale. And then Alison Oliveto, who I think was at UPenn, if I'm not mistaken. Maybe she was at Yale. I don't remember. Okay, Yale, thank you. Yale, and then went to Arkansas. She got an amazingly negative study, but of course it was in methadone patients. And one of the things is, why are all these studies for cocaine treatments done in methadone patients? Because it's convenient. They're there, they're coming every day, but they're a different group and a much more recalcitrant group. If they're in methadone treatment and continuing to use cocaine, you've got a different sample than a cocaine abuser. And I think a lot of the drugs that have been torpedoed have been because they've looked at them in methadone patients and haven't paid attention to that. So because of all of, and I will tell you there's other mixed studies with mixed findings, so the idea was let's get a pure dopamine beta hydroxylase inhibitor. And so we looked at napicostat. I was one of the site PIs that was done at 10 sites throughout the country. And it's a dopamine beta hydroxylase inhibitor. It was actually what happens in substance abuse research is that we get the orphan drugs. We get the drugs that failed other things, and the drug company then says, oh, what are you going to do with this drug? So this was an example of a drug that was being tested for heart failure, failed, and so they said, okay, now we'll test it for cocaine dependence. So there was a laboratory study, but it really wasn't a self-administration laboratory study. It just showed reduction in subjective effects. But anyways, NIDA pursued a multi-site trial. A lot of money was spent, double-blind trial. And I was asked after it was done to write up the results section, which I did. negative every single way, and I'm still waiting for the lead author to write the paper, and he's not excited. He's a program official at NIDA. But I made a career out of negative papers, so I would say, why don't we publish it? So it hasn't been published, but they had a report. This is the benefit of clinicaltrials.gov. The data is on clinicaltrial.gov, a very narrow presentation of the data, and the data is negative. And I'm still hoping it's published, because I think getting out negative trials, in my opinion, is very important. Any case. So what about modafinil? This is another sort of indirect agonist. And Carl Hart did some of the early work, in the laboratory at least, with modafinil. And what he found was that if you gave patients, and I think what I've learned from Richard, talking to Richard now and in the past, is that you have to have alternative reinforcers that are substantial enough. So people were given $25 in this paradigm, and then they had to give back $5 every time they used, which is about what the cost of cocaine might be out in the real world. And what he found is that both the 200 and the 400 milligram maintained on it, that self-administration went down with the dosing. So, that is a great signal for the lab, right? But then, let me go back before I do this, then a person by the name of Verico put out a study. It was a human laboratory study, and it was negative. And so everybody said, okay, modafinil isn't as great as we originally thought. But again, the devil is always in the details. If you look at the lab data, they only had to pay $1 for that drug. So it was low, it was low cost to the patient. So Richard, and I'm going to give him a lot of credit here, and I know he's sitting here, I thought this was brilliant. Richard did this, and I'm sure he had help, but maybe it was all Richard. But anyways, so Richard had this idea, maybe with others, I didn't ask that you really have to look at how a medication works by changing the alternative reinforcers. So what he did was give modafinil and then give doses of cocaine, and of course, at least potent doses, up to 50 milligrams of cocaine. And what he did is that he looked at how people chose cocaine under two different reinforcement schedules. In one situation, people had to press a bar like 500 times, which actually is low cost. You would think that would be pain, but that's low cost. And they had 2 game plays for money. The other group had to press the bar 2,500 times, so you can imagine how annoying that would get. And then they also got 4 plays. And so what he found was that when there was a high cost to getting the cocaine and a better alternative, then they were more likely to choose not to smoke cocaine compared to on modafinil than on placebo. So modafinil worked under those circumstances, but not when the cost was low or when they weren't going to get that much for refusing it. And I think that's a really important clinical point, because when people are thinking about not using cocaine, you have to have alternative reinforcers and reasons that it really isn't in their best interest to continue to use. And we often don't think about that enough when we're designing clinical trials. We just give it to everybody and hope it works. And that's why I think sometimes contingency management as an underlying strategy, as a behavioral platform, isn't a bad idea, because at least you're giving them an alternative reinforcer to make it a little bit harder, a little more thinking about the drug, and then maybe a medication might be helpful under those circumstances. So I would argue that this approach with the high cost of an alternative would be a better way, or maybe a future way, to look at medications for cocaine at least. So what about modafinil? Well, of course, like everything, the first studies that were done were positive. Charlie Dacus, this is where UPenn did have positive studies in which they looked at modafinil as a treatment, and it outperformed outperformed placebo. But then what put the nail in the coffin was a study done by Ann Anderson in which he found that it didn't help at all. But however, what she did find is the people who did not have cocaine, who didn't have alcohol dependence, which is this group, there was a significant finding. So this is my other take-home message, that maybe we're trying to give drugs to two heterogeneous group of patients, and that we have to subdivide, and if half the patients are alcohol dependent and half aren't, maybe this is better given to a patient population that isn't using alcohol. Kyle Campman then went ahead and did a study with cocaine dependence and not having alcohol dependence, and found that regardless if you counted missing data as missing or missing data as using, the modafinil group outperformed placebo. So this was really, modafinil seemed like the wonder drug based on the lab and based on this. But then a large negative trial came out with Charles Dacus, and he, after having done that really positive study, now had a negative trial. He found that it was actually almost significant in terms of 0.06 in men, but it didn't help for the whole population. And this was disappointing. These were people who were cocaine dependent and did not have alcohol dependence. I actually talked to Kyle yesterday, and he told me that Charlie Dacus took the severest patients. He interviewed them and for whatever reason took the severest patients, and that may have torpedoed the study, who knows. But unfortunately, because of that study and Ann Anderson's, which was overall, it's been very hard to get any research done after that on modafinil, although I think it might have some utility. Antagonists are another way to go. Because we have limited time, I'm not going to go through in detail about how they work, other than to say that if you can block an effect like you do with Vivitrol for opiates, if you can do the same with cocaine, maybe that would produce less of an effect. For the sake of time, I decided not to talk about cocaine vaccines. It's an intense area of research. Suzanne and Richard, who are here, have done research in this area. It's very exciting, but as of yet, there's no, obviously approved vaccine for the treatment of cocaine dependence. Indirect antagonists are things that I've described as drugs that indirectly reduce dopamine. So topiramate, gabapentin, all of these agents have been looked at. I'm going to focus on topiramate because that's been the most studied. Topiramate increases GABAergic functioning as well as decrease glutamatergic activity. You really have to use it, as you all know, slowly. And some of the studies that are reported as negative and go into meta-analyses, and then the meta-analyses are negative, in which they did very fast titrations. And that is my other take-home message is, please, if you look at a meta-analysis, go with a skeptical eye, because a lot of these meta-analyses are done and they don't even reach the right conclusions based by the people who do the research in the field. But in any case, there are 2 studies that were done that were quite positive early on. One, again, by Kyle Campman, only 40 patients, but the outcome was abstinence at the end of the study, which is a high bar, significantly higher in the active arm than the placebo arm. And then Bancoli Johnson had another idea where Kyle Campman said, let's make people abstinent and then see if they relapse. Bancoli Johnson said, that's okay, let them use at the beginning and see what happens. And his study also, which was published in JAMA Psychiatry, found there was a significant difference in the active treatment arm compared to placebo in terms of proportions of days of non-use, which is a different outcome, of course, and maybe an easier outcome to attain. But then Kyle did another study. He decided to take the alcohol-dependent patients this time. And the reason he did that, for 2 reasons. One is my guess is that, I don't know if it's a fact, but UPenn was also doing the modafinil study in which they didn't want alcohol-dependent patients. So he might as well take the alcohol-dependent patients. Also, topiramate has been shown to be useful for alcohol dependence. So maybe this would be a group to target, right? And he didn't find anything, and this was a negative study, and this, of course, got NIDA very uninterested in topiramate. However, in that study, people absent at the end was significantly higher in the topiramate group. Again, a high bar. These are people who showed up at the end and were negative at the end. And so, to me, this was still promising. I wouldn't have written it off. But then, again, a negative trial with methadone patients, and that really put the nail in the coffin. And again, like I said, I think methadone patients are a very different population. What about other agents? Well, another approach is doxazazine, which is a selective alpha-1 adrenergic antagonist. There was preliminary studies done suggesting it might be useful. It attenuates cocaine-induced reinstatement in animal models, so there was some suggestion it would work for human beings. And Tom Costin with Zhang and others came up with this interesting idea, is that if you take individuals who have a genotype for high levels of dopamine beta hydroxylase, this is the group that's going to have higher concentrations of norepinephrine, if you can remember that figure I showed before. If they have the CT or the TT allele, they actually have a lower dopamine beta hydroxylase, and so they're sticking with the dopamine and they don't go on to the norepinephrine. And their hypothesis was that an agent that blocks norepinephrine would work better in people who already have lower levels of norepinephrine. At least that was their rationale. They went into the study thinking that. And in fact, what they found was that that was true, that those with the CT-TT allele were more likely to respond to doxazazine than placebo. And then the other group, there really wasn't much of a difference. And I think this brings home another point, that when we get these negative trials, which always happens, unfortunately, in addiction, is you really need to look at the subgroups. And they made this pharmacologic, or I'm sorry, pharmacokinetic and pharmacogenetic theory before they started doing this study and found this, but now it needs to be replicated, and I've yet to see the replication of this, in which you would actually take patients with this allele type and then follow them and see if you can replicate it. So what medications look promising using novel mechanisms? I'm going to skip through all of these. What I say is they all have some promise, but the one that I think has the most promise to date is ketamine. And the person who's really leading the charge is in our division, Elias Dakwar. And the idea behind this is that NMDA modulators disrupt reinforcing effects of cocaine. They are involved in synaptogenesis, and actually, I just found an animal study that looked at self-administration in non-human primates and found that ketamine actually not only reduced self-administration, but also changed functional conductivity and increased it between the prefrontal cortex and the striatal region of the brain. So the idea that there's, I'm not sure how you apply this to from rhesus monkeys to humans, but the idea is that there's sort of some break, or maybe making a choice for another alternative reinforcer. And so I thought that was a pretty elegant study. I'd be curious what other people think of it. But Elias has done the human behavioral laboratory studies, as well as now he's doing treatment trials. So ketamine is one of those few drugs, like, at least to date, like amphetamines, that show promise across all three paradigms. To me, it hasn't lost the irony on me that the drugs that are looking most promising are the drugs that have some abuse liability. So be it. I mean, what we would like to have is drugs that don't have abuse liability, but that's what we have at the moment. And this is Elias's work, in which he had a self-administration paradigm, and he self-administered. People got either ketamine or they could choose $11. They were more likely to not choose to choose cocaine under the single infusion of ketamine, and also mindfulness and less reactivity was noted in these patient population. And the thought was that maybe being more mindful and having less reactivity may also increase the likelihood of them reducing the use of cocaine. This is totally hot off the presses. This got published last week, and I felt I better put it up here because it's great. This is Elias's recent study, and it's a single ketamine infusion with mindfulness to treat cocaine dependence. So now these are treatment seekers. The other study was not treatment seekers. These are people who came in for 5 days, got an infusion, and then they were followed for 5 weeks outside. So it was only one ketamine infusion. Of course, the question is, how long would ketamine work? It needs to be followed, obviously, a long period of time. But what they looked at was abstinence at the end of the trial. People were much more abstinent to become abstinent on the ketamine after 5 weeks than placebo. It was 48 versus 10%. That's like the highest percentages that I've ever seen. But again, he only went 5 weeks out. If more people drop out later on, those percentages would, of course, drop. Our studies generally go 8 to 12 weeks. And again, if you drop out, you consider using. But still, it's remarkable and needs to be replicated. And now he's doing a much larger double-blind trial. Combination pharmacotherapies, that's another way to go. It's really a nascent field. The idea is, well, in hypertension and diabetes, we always think about combining medications. If one doesn't work, you add another. We don't really think about that so much yet in substance abuse treatment, but it is a viable option. And so there was a review done. Nothing's new under the sun. Stoops and Rush wrote this very nice review and just brought up all the different agents that have combined. I'm going to talk about topiramate and mixed amphetamine salts because that's actually what I've been doing with John Mariani and now with Kyle Campman in the last few years. And the thought was, based on everything I've said so far, that there was some signal for topiramate, there was a signal for cocaine, for stimulants, and for dexamphetamine. Maybe combining them, they'd work better. So we did that, and we published in Biological Psychiatry. And what was interesting was the low-level users, there was no difference. And that sort of made sense to me. If you're only using a few times a month, maybe a stimulant and using this heavy-duty guns isn't really what you need to do. But when you get to heavier users, and they really have a lot of craving, and it's much more difficult to stop using, then the higher-level group, people who were using at least 9 days a month, they had a significant finding. So this was a situation where, luckily, we went back tonight and I said, I'd like to repeat this, but I'd like to do it in just the heavier users. Forget the lower users. Let's just take people who are using 9 days a month. We got funded to do a 2-site trial, and I did this with Kyle Campman, who I've mentioned several times already, and we got significant findings. These were our primary outcome measures. Last 3 weeks of study participation or any consecutive weeks, both were significant. Now, the $64,000 question you might ask, which of course our reviewers are currently asking, is, what if it's just all because of the topiramate, or what if it's all because of the stimulant? I agree. I wish I had been funded to do a 4-arm trial, and I wish I had 10 sites to do it at, but that's not what was funded. So, I think that's a further question to figure out. Is it one or alone? I would argue that that's still reasonable because patients liked it. If they took the stimulant in the morning and then they took the topiramate at night, it helped them sleep. They liked the combination. And these are the heaviest users and the people that often don't respond to treatment. So I think it shows something. 2 of the reviewers of this review think it's great, and I'm responding, and one reviewer is saying, where's the proof? So I'm arguing it out right now, but I think hopefully it'll be published. Any case, this defends what I'm just saying to you. Walter Ling published a negative trial, and all over it was negative, looking at oros methylphenidate or Concerta for methamphetamine use disorder. And it was a negative trial, and nobody wants to study stimulants anymore for methamphetamine, although in Australia they're doing just that right now. And the study was negative, and that was what the emphasis was. I felt the need to write a commentary, which I recommend if you read anybody's papers and you disagree, write a commentary, because what I noticed in there was that the people who were low-level users, yeah, there was no difference. You've got a floor effect, right? And they took all comers. But if you look at the people who were heavier users and using more than 10 days, we use 9 in our study, then a significant difference emerged between daily use. So at least this supports what I was saying earlier. And this was only with 54 milligrams of Concerta, which to me is like very low dose for somebody who has a methamphetamine problem. So I think it again demonstrates that there's some signal there. The other thing I've been talking about is contingency management being important. There's a whole host of medications that were not shown to work, dizipramine, levodopa, bupropion. Everybody tried those, and Lexapro. None of it worked except when they used contingency management. And I think that goes back to Richard's point of his study, in that when contingency management was added, then the medication outperformed placebo when the platform was contingency management, in which there was an alternative reinforcer. And so here you see that's the case with dizipramine, levodopa. You see it with bupropion, you see it with citalopram. I think a message comes up with this. Now, interesting, when topiramate was added to contingency management in the study done with the methadone patients, it didn't do anything. So it may be that you have to have sort of more monoemergic activity to see this effect. So I'll end on this because the other part of my research has been focused on comorbidity. I've done research with cocaine abusers and depression, cocaine abusers with flupentixol. Suzette and I were involved in that research together early on. That was probably the first studies we did together. And then more recently, we did a study with looking at extended release mixed amphetamine salts, 60 milligrams of Adderall and 80 milligrams of Adderall, which is more than the FDA-approved dose. I'm very grateful that NIDA approved it. I'm very grateful the FDA approved it because these are, probably twice what you would give in clinical practice. And it's a double two-site trial. And what I'll tell you is there's about 10 or 12 studies that have been done with substance abusers with ADHD. Most of them are negative. The negative ones, a good percentage of them are mine. And why are they negative? Because I didn't use the right dose. The bioavailability of the earlier drugs were much lower. I was dosing several times a day. I'm giving you 30 years of clinical mistakes and designing my trials to get to the point of knowing that, you have to give daily dosing. You don't want to give multiple doses. You want to give potent dosing. You want to make sure they show up. All these kinds of things took me years to learn. I did learn them eventually. I had help in learning that. So I had negative trials. So by the time I ran this trial and put in a grant with this trial, I had, I think, most of the things in place that would at least give it a shot. And so high enough dose, adherence played a big role, making sure patients taking their medication, voucher incentives for showing up. And under those circumstances, and this is not found in a lot of trials, even for ADHD and stimulants, is that the ADHD got better on both doses compared to placebo, significantly so when we looked at mean changes. So this was good to find, and these was a significant effect. But the holy grail is what happens to the cocaine use, and particularly in comorbid populations, which are much harder to treat. And what we found is that those on placebo, which is the top line, when we looked at weeks of urine abstinence, so we made sure that for each patient we had to have at least 2 urines present out of 3, and they had a self-report. We used self-report as well. And if they self-reported that week as negative, along with the urine support, then they were a negative week. And what you can see is if you count missing data as missing, and therefore, you don't have bigger ends at the end, you see that there's definitely a drop in positive weeks, proportion of positive weeks for the 60 and for the 80. It was lawful, it was what we expected. And then when you count missing data as using, which is a higher bar, it works against your data, again, it was significant. So this was quite a strong finding. Now, would I say, absolutely it's true? No, we need to do it again. Good luck. Good luck trying to do this as a multi-site at this dose. It really needs to be repeated. But I think this data in and of itself is strong, but we can't go by one study. Also, the high bar I told you about, abstinence at the end and showing up at the end, we had about 70% retention, so you're already losing 30% that you have to count as using. So these numbers actually aren't so bad. And what you see is the 80 and the 60 outperform placebo and abstinence at the end of the trial. So this, I think is quite notable, but again, needs to be repeated. I mean, what we have found over the years is you get positive studies to begin with, but also the bar has gotten higher and higher. You know, when you put in a paper, they want to see all the data, both missing and not missing, intent to treat and completer. They want to see all of that so that they don't feel you're cherry picking the one thing that would be positive. So in conclusion, what am I going to say? I think long-acting formulations of amphetamine in frequent users with or without ADHD shows promise. Modafinil without alcohol use disorder and perhaps in male. I think the jury is still out about modafinil, but you know, there's little interest in getting funded for that. Topiramate, I also think shows, if you read a meta-analysis, they'll say there's no evidence that topiramate work, but there's only been 2 studies that have looked at absence at the end of the study, and those 2 studies were positive. So I think we have some ways to go with that. Doxazazine, certainly ketamine is very exciting, and we're doing work in our division on that. Combined treatment, I mean, clearly it's interesting. I think it needs to be replicated and done in a 4-arm design. I think what we often forget to do, and we should be thinking more in terms of cocaine treatment, is evaluating subgroups. Maybe we should be looking at low frequencies versus high frequencies. Kyle has an algorithm of people with severe withdrawal symptoms at baseline or severe cocaine severity as an outcome, and has found differential effects based on that. Psychiatric subgroups, I think, are critical. There's almost no research done, a little bit in depression, a little bit in ADHD, but really not that much work in that subgroups, genetic subtypes. I think combination therapies are very promising, but again, it's very hard to convince review committees to study combination approaches. I didn't have a chance to talk about vaccine research, but that's also very exciting. And as I said, in all of these trials, it's critical that you make sure that there's a way to ensure adherence. In most of our new clinical trials, we actually have a MOCA where we have patients daily looking at their smartphone and watching them take their meds. Could they still cheek it? Patients can always get around you, but at least it's another area of being able, another way besides riboflavin or pill counts. I mean, we do that too, but it's another way to ensure adherence. And I think all of this, everything I've said today, is impacted by how we define treatment outcome. What should be the bar? Is reduction in use enough of a change? We need other data to support reduction in use. In the alcohol literature, there's a lot of data supporting that. If you go down to 1 drink a day, it really improves your morbidity and mortality. We don't have those kind of answers for cocaine or for marijuana for that reason. And on that note, I'd like just to thank NIDA and thank Carl and everybody, Kyle, who's been instrumental in working with, and all the PIs at STARS. Again, this is herding cats, so about half the people aren't here for various reasons, and the statisticians are critical. And then a special shout out, I don't know if Ned is here right now, but he was busy. There he is. I don't know, but Ned was here, was going to come if he could. But Ned needs a special thanks because a lot of these work over the years have been in conjunction with working with Ned and bouncing ideas off of him, and he's been critical as well. And on that note, I will stop. Thank you. I'm sorry I went over.
Well, thank you so much. That was such a wonderful review in terms of thinking about potential treatment options for patients. I wanted to just open, you presented several different medications which have some promise, and I'm wondering in your clinical practice, among the ones you mentioned, what do you go to first?
Okay. Yeah. The one that I go to actually is modafinil, unless they're complaining about sleep or that, then I'll use topiramate. I don't use dextroamphetamine that often. I've done it a couple of times. I think it's fraught. I think it's much better done in a clinic setting or where you can see patients frequently during the week. My practice is limited, so I've got to sort of trust that things won't get out of control. A person who uses it a lot, I know, is John Mariani, who has a big practice and sees patients regularly every day, and he's a big supporter of it. I think if you're going to do it, the long-acting formulations, and I think lisdexamphetamine is what we both have fallen back in using. Lisdexamphetamine, the grant that I put in, which has not been funded, but was looking at 140 milligrams of lisdexamphetamine, which is about 60 or 80, or 60 maybe of dextroamphetamine, and there's much lower abuse liability with a long-acting formulation. There's actually a group in Australia right now that's looking at 250 milligrams of lisdexamphetamine for amphetamine use disorder. And I said to them, well, are you monitoring blood pressure? What are you doing about that? They said, we're not looking at blood pressure. I go, oh, okay. So So, yeah, so I was in Australia. But that was sort of an interesting experience at the posters at CBDD. But yeah, I mean, that would be where I would go first.
Questions? Yeah.
Hi, Fran, I enjoyed that very much. I just was struck by one comment you made that, cocaine was the second most after marijuana abused illegal drug in the world, I guess, or
Yeah.
at any rate in this country. And one of the reasons, obviously, that propelled the decriminalization of marijuana was the unfairness of the application to people of color who got much worse penalties and prison terms and so forth. Are you concerned that that cocaine will be next? That is to say, it's well known that people with crack cocaine get punished and put in prison much longer than people who are using powdered cocaine. Are you concerned that now we'll get to this one, because that's such a powerful motivation for decriminalizing these drugs,
Right.
that the next step will be to decriminalize cocaine?
It's more of a point you're making rather than a question. I agree with you, and I think that Richard would probably know, but Marion Fishman wrote a very nice review about the racial bias associated with crack cocaine versus powdered cocaine, and it's still cocaine, and why are we setting up criminalization targeting crack? And I think it is a concern that as cocaine use goes up and we're less concerned about marijuana, that, I mean, it's political, but like the prison system, is a large organization that needs to be fed, and if they're not fed any longer with people who get incarcerated because of marijuana, it could be because of cocaine, could become the next problem. So I think we should keep an eye on that. I don't know, Richard, if you wanted to add anything to that. Yeah, that's fine. Thank you.
I was one of the people responsible for the law that said crack cocaine should be, people who use crack cocaine should be criminalized more than people who use powder cocaine.
Biden.
Yeah.
Yeah. Okay, so you when you have a history, people pull it out and remember that, right? Yeah.
Yeah, I have a question about methodology. The slides and everything were wonderful, but in terms of the complexities of individual metabolism, we did studies a number of years ago about the complexity of something as simple as dizipramine. And all drugs go, obviously, from stomach to the liver. And the liver has a memory for past experience. So the way the drugs metabolize, now, for example, I wonder in the infrequent users, there are several metabolites of cocaine. Do you check for the pattern of metabolites? And the same is true as dizipramine. So the range of sensitivity, let's say for dizipramine, we get a blood level, can range from 30 milligrams to 600 milligrams.
Right.
Because of absorption and liver metabolism. So I wonder if a more closely monitoring of what metabolites they're making from either or both the dizipramine plus the cocaine. And maybe the cocaine users have a different set of metabolites that permit them to get away with it 2 or 3 times a week.
Right.
So I would think checking urines and liver metabolism would be a worthwhile thing to do in adjusting. You adjust the dose levels of modafinil, so you could take, for some people, and I've done this, up to 600 milligrams of imipramine or dizipramine, and maybe you do better with more intimate measurement of the individual.
Right.
And I guess the question of the social context is also hard to measure.
Right.
Are these using solo? Are they using with other people? And but
Yeah,
the
I mean,
closer measurements of
yeah.
monitoring would help determine frequent users and the genetics as well, because the genetics are affecting metabolism.
Right. I totally agree with you. I think that's like another level, and I think that people haven't done that, and I think it probably, it's more noise, making it even harder to see a difference. I think if you have, in theory, a large enough sample and you've randomized, hopefully people wind up in the opposite group so that it washes out. But when you only have 100 people in a study and half drop out, I think it's hard to do that without that. The other thing that was a big area of argument, actually, between John Grabowski and me is he was a behavioral pharmacologist and was very lawful and felt that in the ADHD treatment trial that if somebody didn't tolerate the dose they were assigned, they should be taken out of the trial. And John and I argued vociferously, maybe because we're clinicians and we don't know any better, but we said we're going to do flexible dosing, which doesn't address what you're saying in a perfect way, but if somebody is not tolerating a dose for side effects or they're getting exposed more, we could back off. So in fact, we did have a good number, many patients who we had to lower the doses. So I was a little, I won't say deceitful because it's a matter of time, but on that 60 and 80 milligrams, the average dose in the 80 milligram group was about in the low 70s, and in the 60 milligram group, it was about 54. So people, we did back off on the medication dose, so it was fixed flexible dosing. If we had just dropped people who didn't tolerate the top doses, we wouldn't have had any data, we would have lost a lot of people, and then it wouldn't have been found, the differences that we found. So I think your way is much more elegant than just responding to what the patient's telling you in the clinic, but that's what we did, and that's what most people have done. I think very few have looked at levels. I think it's been, I can't remember the literature well, but I remember in the deep part of my brain that the earlier studies with dizipramine, 1 or 2 of them did do at least blood levels for dizipramine. I'm not sure they looked at any of the metabolites. So, but thank you for that question.
Hi, thank you so much for being here. I had a couple of, I wondered if you could speak a little bit about a harm reduction approach specifically around syringe exchange programs. Do you find that could be at all part of the modules that you just listed? Is it a novel mechanism? Is it part of contingency approach? Do you see it at all in treatment? Tell me your thoughts.
Well, I think most people, and I wish Robin was here, who done a lot on policy, but one of our faculty members, but I think that harm reduction, I think, is an important way to go with many patients who aren't yet ready for treatment and still want to use, and at least you want to keep them safe. And there is some thought that through needle exchange as one form of harm reduction, that patients wind up over time actually using less, not more, and they also eventually a percentage will engage in treatment. That it's an opportunity that if you have an engagement with a patient or a participant or a client, they're not yet a patient, that there'll be more of an option, that they'll be interested. And I think that that was the approach of the Amsterdam group, is that when people have failed other standard approaches, in Amsterdam they have heroin-assisted treatment centers, and people can get treatment for heroin, and they don't think it's controversial at all. When I talk about ADHD, treating substance abusers with ADHD with the stimulants, I have this whole 5 or 7 slides on why it might be okay, and I'm tentative, and the people in Amsterdam and parts of Europe, they look at me like, yeah, so, no big deal, of course, Here in the US, we feel very strongly against giving a controlled substance to somebody with a substance use disorder. That's why I find it a little ironic that in the end, I just realized as I was talking to you today that 2 of the most drugs that show the strongest signal right now, ketamine hasn't had that much research yet, so we'll see with ketamine, but dextroamphetamine, long-acting formulations, seem to have the most promise to date. And what NIDA, is desperately wanting is something that works as well, but doesn't have the addictive potential. And that would be ideal, of course. But look, we're using buprenorphine. I would argue we're using buprenorphine. And yes, there's diversion and there's issues, but by and large, it's saving a lot of lives and preventing overdoses. So I think you have to decide where you fit on that spectrum, how much you care about reducing harm, like you're suggesting, saving people's lives if it's overdose with opiates and buprenorphine, versus the concern, which is a real one, about diversion or misuse. So people feel differently across that spectrum. Okay. Oh, one more? Okay.
So is there a primary toxicity upon the brain of cocaine? Aside from diverting attention from all other hedonic activities, behavioral things, what does it actually do? Suppose you take it and then or they take it and they stop it completely. Have there been any effects on intelligence or any other?
Yeah, as far as I know,
disorders,
and somebody can, Richard, somebody else in the audience can correct me, but I think that once somebody, not so much with intelligence or IQ, it's been more shown a little bit with heavy, chronic, early users of marijuana, actually, than cocaine, but early cognitive deficits that seem to improve over time, particularly brain scans such as PET imaging and others show that the deficits or the decrease or hypometabolism that you see with cocaine seems to improve after months or 6 months, and Nora Volkov has done a good amount of that work. If you take somebody who's extremely heavy user and has had strokes as a result, that's probably not going to improve, but people who in theory haven't experienced that level of cognitive deficits, there is brain scanning that has shown improvement. Also, now there's a lot of work in functional conductivity and showing that with chronic cocaine use, there's reduction in the signal between the prefrontal cortex and the striatum, suggesting that you lose that sort of top-down control, and that may contribute to why cocaine becomes easier to use and more reinforcing and harder to quit. But there's been, it's not my area, but certainly this has been well-studied, and usually most of it improves.
Not microvascular disease, for example, which they talked about with methamphetamine and all.
Right.
They don't talk about that with cocaine. That it causes.
Not to the same degree. I don't know, Richard, have you heard anything with cocaine in that way? No, he's agreeing with me, so I feel better. Okay. Okay. All right.
Did you have another question?
If nobody else has a question, I'll ask another one.
Okay.
In terms of receptorology, let's say we know there's a mu receptor, kappa receptors for opiates. Now, so there's no receptorology one can study for cocaine in terms of
Right.
an area of the brain you can make something more targeted.
Yeah.
Is that correct? There's no.
That's correct, and that it works more on the transporters, or it works, indirectly. It doesn't, it's sort of like alcohol. There's no alcohol receptor, so to speak. And where there is for marijuana, right, with the endocannabinoids. So yeah, it makes it, I think, harder in some regard. Yeah.
I think
That's
that's
your
part of
point.
the problem is
Yeah.
that there's no specific receptors out
Right.
for the other drugs.
Right. All right.
Well, I hope everyone enjoys the summer break, and please join us for lunch to
Thank you.
continue the discussion.
Thank you.